Welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED CT Expo 2022. My name is Nick Egerhaus. I'm the Global Vendor Engagement Lead and Customer Relations Executive for the Middle East and Africa with SNOMED International. And I'll be moderating today's session. Lucky you. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A box to type your questions to the presenter. On-site attendees, please use the microphone provided. I'm now pleased to introduce Marlo Verket from the University Hospital Aachen, who will be presenting DARIO, Digital Diagnostic Support of Heart Failure with Artificial Intelligence and SNOMED CT. Marlo, the floor is yours.
Thank you so much for the lovely introduction. So as you guys all heard, my name is Marlo Verket. I am a research fellow at the University Hospital Aachen in Germany. I know it says online Denmark, but it is Germany. I just wanted to make sure to have first a disclaimer. I'm not a doctor. I work with a lot of doctors and work with a lot of study nurses, as well as our programmers and software engineers. So I'm kind of the middleman between trying to go back and forth. And so that's why we'll start off a little bit medical at the very beginning. I'm going to talk about heart failure and why it's such an important topic to have such tools as the digital diagnostic support tool that we're trying to try to develop. And then, and what we're doing right now in the project itself, we're still in the very development phases. That means that I'm going to show you the abstract ideas of what we want to do and where we are at right now. Next slide, please. Just a financial disclosure, we are funded by the German Federal Ministry of Education and Health. Next slide, please. So, as a good portion of you guys probably already know, heart failure is a quite deadly disease. In Scotland, there was about a 5-year survival rate where they showed that in men, heart failure was more prominent than, for example, prostate cancer or even bladder cancer. And as well in women, heart failure was way more prominent than breast cancer and was on par after 10 years with ovarian cancer. This mortality rate is really, really high. We need to figure out how to stop or at least prevent some of these deaths in the future. Next slide, please. So just a quick overall how we currently assess heart failure in patients. Patients will come in with either shortness of breath, they will have either ankle swelling, they're a bit fatigued, and a lot of these symptoms are quite broad in general, and sometimes it's really hard to figure out if it's heart failure or something else, or if it's something with their lungs and such. They usually come with additional risk factors, for example, being overweight, or if they have hypertension, as well as diabetes and metabolic syndrome. And of course, when people are older, for example, over 70 years old, in men over 60 years old, in women, that has a tendency of raising the risk for it being heart failure, as well as COPD or sleep disorders. Next slide, please. And we can also then run tests, some blood tests, and the main lab value that we always look at is BNP or NT-proBNP, and we look to see if it's over a threshold. If it's over these thresholds, then we go in for an echo, and then you start the process of medication and this, that, and the other. The European Society of Cardiology guidelines had recently a new guideline for the diagnosis and treatment of acute and chronic heart failure, where they defined then the different heart failures or phenotypes of heart failure. So heart failure with reduced ejection fraction, HFrEF, which is then the left ventricle ejection fraction, which is less than 40, that means when they look in an echo, they see if your heart is pumping and how it's pumping. And if it's able to pump really, really well, and you still have a lot of symptoms and your BNP is over 35 picograms per milliliter, then you would be probably under the heart failure with a preserved ejection fraction, because then you have over a 50% ejection fraction rate. However, these phenotypes are very heterogeneous within. So when you look at the patients that are classified as HFpEF, they have sometimes a really different characteristics than the other person right next to them who's also classified with HFpEF. Next slide, please. Oh, one slide before. Thank you. So that's one of the big issues, particularly in HFpEF, is that one, it doesn't get diagnosed early enough, and even properly diagnosed. Usually they are then in HFmref, or they think it's completely something else, like atrial fibrillation and just atrial fibrillation, and not for HFpEF itself. And when these aren't in a timely manner, then this leads to improper therapy strategies, which in turn leads to the high mortality rate that we saw at the very beginning of this presentation, which in turn increases also hospitalization rates, which of course is very costly. And we just go down a really, really bad pigeonhole. And these data and critical information, we believe, or we hypothesize, maybe could be found in unstructured documents, such as what you get from the doctor, especially in Germany. We still work with, you are at the doctor at the end when you leave the hospital, you receive a letter saying what you had, how long you were at the hospital, and it's basically in a text. The doctors probably did it in Word, typed it all out, and then you get handed per hand. And so that's where we find that SNOMED CT could really, really benefit in helping find these critical information and be able to do text mining in such documents in order to then have a better analysis tool for later. And over 50% of patients with heart failure are not even diagnosed. Next slide, please. So we decided for DARIO that we would like to develop a diagnostic support tool for HFpEF, and really for heart failure in general, by identifying the risk in order to streamline and simplify the diagnose, to reduce misdiagnosis and failure to diagnose. Because currently there are a couple of risk scores. However, they have a lot of extra tests that the doctor should use. These tests aren't always covered by the health insurances, and they're kind of expensive. And so that's why a lot of these tests don't even get done. And that's why we wanted to develop an interoperable software application that uses artificial intelligence to recognize HFpEF, and hopefully then have an integrated data view with evaluation of interesting data clusters and constellations of how that works. We would try to make it as easy as possible for the clinicians so they could have a quick look at the application and already know, oh, are they potentially high risk for HFpEF? Yes. Okay, we'll put them on. Oh, it needs more tests. Then they have the lovely orange light, or no, this is not a case for HFpEF. Let's look at something else with a green. Next slide, please. So some of our key elements is we're starting at the very beginning right now, is just prepping and integrating the acquired data or the necessary data for this, to develop this application, and be able to do clinical annotations like SNOMED CT, and as well as LOINC codes as well. Then from there, we will do a clustered analysis for phenotyping and characterization, as well as trying to develop AI based classification with different models and such. Then we want to create a prediction model from that and try to then do a front end where you would have a view for the clinicians, as well as then document all our developed product, and as well as have a clinical feedback and have the clinicians look at this, see where we could adjust and improve our application. Next slide, please. So when you look at the clinical annotation sizes, particularly SNOMED CT, and you just type in heart failure in this international SNOMED CT browsers, you get about 173 matches. The ones that you can use for the ICD codes are only about 5. For HFpEF, for HFrEF, there's about 4 of them. And for heart failure in general, there's about 2 that we found that really regards this. What is also a little bit of a hindrance in the German world is that the German version of SNOMED CT is not officially online. And so we're trying to also help our government authorities, it's called BayFarm, be able to translate these things and make sure that, for example, when we're translating it, it would probably hopefully help them with this translation of the huge browser. Next slide, please. And we would also need to map to other comorbidities and to other lab values, therapy, and tests, for example, lab values like cholesterol, triglycerides, LDL-C and such. A lot of these patients are on statins or SGLT2 inhibitors or DOPA1RA. And this makes it just these patients have a lot of therapy, have a lot of problems, and are very complex and not just the standard, I just broke my leg, I need help type of thing. Next slide, thing. So first, we're digitalizing our clinical documents. This means that I get to have the fun task of pseudonymizing our paper. And basically that means taking a black marker on about 1,000 clinical documents and trying to make sure that, you know, our patients' secrets or at least not have data security and are not promoted anywhere. And then we are mapping these to SNOMED CT and LOINC annotations. What's another problem with these clinical documents is that they are all with acronyms, and our doctors love to have, for example, instead of just saying diabetes type 2, it'll be T2DM, which means diabetes, type 2 diabetes, and being able to then take that and first translating it into what it would be in German, then translating it to English, and then mapping it. So it's a bit of a like 3-step process, especially when it comes to certain things. Or for example, for us, we have an Oberarzt, and a lot of times that will be with OA with double points on top of the A with umlaut. And that's also been that's provided a problem for a lot of our programmers, because then sometimes the text with the OCR engine doesn't really register that it's in a special A, and trying to figure out how to work with that sort of thing. Next slide, please. Then when we finally get the documentations in order and that all digitalized, then we will want to phenotype and characterize HFpEF patients and see if we can find a little bit more of a detailer and a specific idea of how to characterize these patients. This includes text mining, as well as using AI methods such as decision tree or recurrent neural network in combination with Shapley additive explanations. Next slide, please. This in turn, because right now in Germany, it's also very big on trying to have a data integration system in place in all the hospitals. So that means we are developing a FHIR profile as well. in with this support tool that relies on a couple of major governing factors. For example, the MEE, which is our what is it? It is medical innovation integration, and trying to enable, because everyone wants, when you say fire profile, that's not the same fire profile for everyone, and trying to integrate it so that we can be as interoperable with other hospitals and clinics. Next slide, please. Then in the future, hopefully in the next 3 years, we will do a feasibility test study, and hopefully we'll be publishing that as well as, of course, documenting all of the attributes in the study itself. Next slide, please. And this is basically where we want to sit. We want to sit with within the healthcare. We want to be able to integrate, particularly with patients with a high heart failure risk, and be able to have an early diagnosis and a timely prevention, and to optimize treatment strategies in order to reduce the amount of people who go into the end stage heart failure and potentially die. Next slide, please. And that's really our big intake, is that if we start using SNOMED CT to be able to optimize such tools, and then we can find these problem patients earlier, which then reduces hospital admission, which hopefully then reduces more death in the end. Next slide. And this couldn't be done without a very multidisciplinary consortium. I would like to thank our bioinformatics and our Institute for Medical Engineering, as well as all the doctors who helped me and make sure that we are correct in identifying these patients. Next slide, please. Thank you so much, and I'm here for any questions.
Great, thanks very much. Any questions from the audience?
Thank you for a very interesting presentation. Yeah. I used to work in Germany for a couple of years as a doctor, and when I was working there, I actually never heard of SNOMED CT before. So I'm just curious to know how well adopted is SNOMED CT in Germany currently. Is it used in EHR, or do you have to do all annotation manually?
So we have to do the annotation manually. It's right now not even integrated. A lot of hospitals are kind of waiting for the official translation, and we're trying to push that we don't need this official translation. We can start using it within our systems. And so it's still very, very new. And we're trying to push the government to also put it in our electronic health care records for the patients as well.
That's really interesting to know. And second question, when you're using all the unstructured and structured data for analysis, do you actually face any problem with like data privacy regulations, and how do you have to get the patient consent to be included in the studies?
So right now we're doing all retrospective data analysis. So that means we are using clinical documents that have been published in the past, and the patients are no longer there. We do make sure that the patient's name, date of birth, where they are from, who are their doctors, are not found on the clinical documents, so that it is a pseudonymized clinical document. We did have to go through the ethics board, and we did we covered all our bases in that regard. Yes, because Germany is very very into their data protection.
So you have already defined the parameters that you will use in your model for the AI analysis? Or,
not
because
yet.
You have indeed shown different lab tests, for example, and is it all what you will use, or will you use a larger data set on top of
So we're
the
gonna-
SNOMED CT?
So when it comes to the SNOMED CT and the data set that we currently have, we are trying to make it as pragmatic as possible so that other hospitals could actually use this. So that's why we haven't tried to order more tests or we want to see what's there for the patient and use that and see if that works. And then we'll go from there. And so we will be looking at the lab values that you get at a common, when you do your blood tests, what you commonly get when you go to a cardiologist. We will be using that and we won't be ordering any extra tests or anything else to try to make sure we can actually integrate it in the hospitals.
Okay, time for one more. Anyone?
Yeah.
So when this all works, and it'll be great, and you've decided on your parameters for how you diagnose which type of heart failure is which, will it be like an alert that comes up on the screen? I used to be an echocardiographer, so that's why I'm just really interested. How do you envisage that?
So it would be great in the future, like this is way, way, way in the future when this is totally validated and everything works and it's 100% reliable, that it would be great. That would be more of an alert, that the patient comes in and all the tests will be run through. What we're probably going to do now is that the doctors themselves have to go into this module that is linked to their hospital administration system, and then be able to then collect the data from the system and be able to run these tests and then show the results. But yeah, it would be lovely to be able to do alerts and such.
Okay, one more question.
For training the system, do you have already an estimation of the number of patients you need?
So we are using, to train the system as well, we're using the Mimic 2 database, but because we were able to see that we have a lot of the same lab values and such, and try to work with other big registry data sets to be able to train the system as well. But we are running into issues with different healthcare systems, which leads to different like lab values and different parameters that are emphasized in different health systems, and trying to figure out how to balance between all of that. Thank you.
Great. Well, thanks for all the great questions. I think with that, we'll conclude the session. Thank you, Marlo.
Thank you.
And online delegates, you can join another session through the event lobby. And on-site, if you're playing our event game, scan the QR code by the door to capture your attendance. Thanks again.